Good morning, everyone, in our lovely and sunny African continent. This is our first virtual workshop on the front of the lower limb.
Yes.
I am Lisa Mudola. I am an anesthetist from Kenya. And with me today is Dr. Mohamed. He's a consultant anesthetist and the lead of regional anesthesia at the North Cumbria Integrated Hospital, United Kingdom. Hi, Dr. Mohamed.
Hi, how are you? You okay?
I'm fine. How are you?
Good.
Good. So, Dr. Mohamed, I just have a couple of questions for you today.
Excellent. Okay, ready?
First of all, can you tell us, Dr. Mohamed, about the anatomy of the femoral nerve?
Yes, so thank you very much, Lisa. So basically what we are going to speak today is about the front of the lower limb, including the femoral nerve, fascia, ileaca, and this is what we call bland A blocks. We'll do the tutorial now, and then we'll move to the scan. So the femoral block is one of the branches you can see here in the slide. It's one of the branches of the lumbar plexus, L2, 3, and 4. And this is one of the other, they have another branches, which is very important as well for the hip and the lower limb, things like the obturator nerve, the lateral cutaneous nerve, the iliohypogastric ilioinguinal. And the femoral nerve is really, as it travels down over the iliacus muscle and below the through the pelvis and below the inguinal ligament, as you can see here, it divides immediately as it travels as goes below the inguinal ligament into anterior and posterior divisions. It gives a lot of innervation to the muscles, to the skin, and to the joints. So the anterior division give you to the hip joint, give you also a pectineus and sartorius muscular innervation, and give you a cutaneous innervation for the front of the thigh. It does have an intimate relation, as you can see here, to the vessels, including the femoral artery and femoral vein, enclosed, medially enclosed in the femoral sheath. So the femoral nerve lies a bit lateral to them. It's very important to do any blocks, to know more about the surface anatomy, to know about the muscular relations. So the muscular relations for the femoral nerve does have a very important relation to the iliacus muscle and the psoas muscle, which come together at the iliopsoas tendon, to have a common insertion to the lesser trochanter. It's given that, as I mentioned, that in the posterior division of the femoral nerve have also another important branch, which is called the saphenous nerve, which gives you a cutaneous innervation to the medial side of the knee and to the leg and foot. As you can see here also, there's another important muscle called the sartorius, a slender muscle coming from over the anterior superior spine and insertion to the proximal tibia, and it's extremely important in identifying the femoral triangle and the adductor canal, where we can do the adductor canal block, which is type of ambulatory nerve block, which you can avoid the weakness for the quadriceps gained by the femoral nerve.
Thank you. That's a very good overview.
Thank you very much.
Now, could you please tell us some clinical indications of when you can do a femoral nerve block?
Yes. So the clinical indications for the femoral nerve blocks or any other blocks is always it's better to understand the dermatomes, the myotomes, and osteotomes innervation for the nerve. So if you know that well the territories of the nerve, you will know which indication is which surgeon's indication or what's the indication of these block. So as you can see here, that the femoral nerve block does have a massive innervation for the upper part above the knee, including the skin of the anterior and middle side of the thigh. Also does have some osteotomes to the femur, plus the muscular innervation to the quadriceps, which is source of pain, especially femoral fracture, because of the spasm. For also the cutaneous supply, you have the saphenous nerve, which is one, as I mentioned, it's one of the branches for the posterior division, which is travels down, and this is the only part of the femoral nerve which goes below the knee to supply the medial side of the leg and medial side of the foot, and can be considered as part of the ankle block as well. I think that's also indication things like pain relief for the hip joint, pain relief for the femoral fractures or the femoral fracture, skin graft for anterior thigh. This is all, as you see here, it's you can get it without even knowing the indication when you know better about the territories of the femoral nerve.
Okay, thank you. Because now we know where to use the femoral nerve.
Yes.
Now, Dr. Mohamed, do you have any special techniques or tips that you can give us when we're doing the femoral nerve block?
Yeah, so as you can see here also, for one of the technical tips when we're doing a femoral nerve block is first you have to know the safety precautions when you do any blocks, including the ultrasound probe. So this is a superficial block, so you don't use a curved probe, use a linear high frequency probe. Adjusting your settings in the ultrasound machine, adjusting the depth is no more 3 to 4 centimeters. Your needle is about 50 millimeter, 50 to 80 millimeter. That's enough for doing this block because you can't easily manipulate it around the nerve. One of the things also is very important is your ergonomics. When you're doing any blocks, it's very important to do it while you are at easy position for you and for yourself to do an easy and safe technique without being tired. So if you have a sore back and you're doing this block and you're not happy about the position, you will be tired and you will lose all your technical bets when you're doing the block. Again, one as you can see in the slide here, safety is very important. It's better to know where is the interlibit before you're doing the block. As you can see, the femoral nerve is very close to vascular structures like the femoral vessel, so there is an accidental intravascular injection. So you have to know if you're having your theater interlibit for local anesthetic toxicity. I think that's all. Also, one of the most important technical aspects, as you can see in the slide here, is know the anatomy of the muscles. So as you can see, the sartorius, you know the iliacus muscle, you know the fascial layers, the fascia lata and fascia ileaca, and the nerve appears immediately when you know all this structure. It becomes much easier when you're identifying the nerve, when you know all about the structures which you can do it. And I will show also the nice video here, where you are, it's something is called in-plane technique. So you need to see the whole length of the needle when you're doing the block, and you can see here, and your needle comes from lateral to medial, and while the needle travels through the skin subcutaneous tissue, it pops and pulls the fascia iliaca, and as it pulls the fascia iliaca, it goes into the nerve. Don't transfix the nerves, don't go through the nerve, create a pocket of local anesthetic underneath the nerve, so your injectate will be below the nerve, and you can manipulate about, actually you don't need much really redirection of your needle. So what you can do is just you do the injection below, create a pocket, you can do another injection above the nerve, and that's it. Maximum volume about 50, I would say 50 to 20 ml of local anesthetic, according whether you use it for analgesia or using it for anesthesia.
Okay, so those are very important tips. Thank you very much.
Thank you.
So for the last question, Dr. Mohamed, you've told us about the fascia iliaca block as an important block to learn.
Yes.
So what is the fascia iliaca block, and what is the difference between suprainguinal and infrainguinal blocks?
Yeah. So the fascia iliaca block is one of these blocks which is we call it Lisa field block. It means that you are field fascial block, which means that you're injecting a large volume of local anesthetic within certain fascial layers to involve number of nerves. Things like the erector spinae. In the back, you heard about the erector spinae. This is a field block. This is a fascial block. Also, one of the most common is the fascia iliaca. Fascia iliaca gained popularity since 1989. You imagine that. So it's one of these blocks which is actually described in literature by a pediatric anesthetist, described the two pops technique, which is a blind technique, just lateral to the vessel, you dividing the femoral crease into 3/4, so the junction between the medial 2/3 and lateral 1/3. This is the side of your needle entry. Feeling the two pops, know that it locks. It sounds easy, but it's not as easy as it sounds really. There's also the suprainguinal fascia iliaca, and this is another technique, which is again another field block. You need a larger volume of local anesthetic. I would say, I repeat it again, larger volume of local anesthetic, at least 40 ml of local anesthetic, bupivacaine or levobupivacaine 0.25 to give you a good effect of the block, and this is done at the level of the anterior superior spine, and we'll see today while we're doing the scanning. So we'll traverse the probe, and then we'll see, you can see it in the video here. So you can see the landmarks, you can see the what's called the pore sign, where there is the internal oblique in one side and the sartorius on the other side. And the idea is to create a pocket of local anesthetic where you're injecting above the iliacus muscle, below the fascia iliaca, and inject larger volume as a travel proximal as you can to involve the three nerve, which is the lateral cutaneous, the femoral, and also we hope that it's the obturator, higher branches of the obturator and femoral to give you a very good analgesia for femoral and hip fractures here. You see in the video, there's another, can you see the vascular structure? This is superficial circumflex iliac. You have to be very careful when doing the block. As you can see here, also avoid injection without the muscle. So this is very important tip again while we're doing this block. And we will have all of that while we're doing the scanning today. All right?
All right. Thank you so much, Dr.
Thank you. So we hope we get better with the scanning. Okay, move the scan.